All right, everyone, welcome to another lecture with EMSconnect. This one is one of our BLS sessions that we are targeting at our EMT level providers. Couple of housekeeping disclaimer slides as we get started here, and then we'll go into these great case scenarios. So one of a couple of disclaimers. Disclaimer number one, we are presenting on national curriculum, national content. We do not cater to a specific protocol or to a specific state or county. So please make sure that you follow your local protocols, the direction of your medical program directors or your medical program director delegates, and make sure you are providing patient care according to those protocols. But if you do have questions about some of the topics that we're talking about, please let us know. info@emsconnect.org, and we can get you in touch with one of our faculty physicians and or providers to help you make some of those protocol changes. So make sure you let us know if you have any of those questions. Second disclaimer is our AI disclaimer. We may use AI generated closed captions or AI generated images. These are just to enhance your learning experience. So understand that some of our images we might use could be AI generated. And our third disclaimer specifically for today, we did reach out and get some great case presentations that are real case presentations from agencies. So understand that we redacted any HIPAA related information, anything related to their health information. But just understand that things written in all caps, especially, we took directly from those reports. So if there are misspellings or grammar issues, those were not changed so that we could just use these case studies as pure as they came. So for those that submitted that, thank you very much. It will make this lecture even better. Interacting with us, myself and Quinn, ready to answer your questions, interact with the scenarios we're going to go through. Depending on what platform you're on, whether that's commenting, that would be great. We got people monitoring those comment boxes. And if you are in the webinar, our regular questions tab is open for us to answer those questions. So please feel free to throw those in there, and we will answer those questions in real time. Introductions. If you haven't joined us before, my name is Shaun Pitts. I'm the head of education here at EMSconnect. I also host the On Shift podcast found on all those major podcasting platforms. I'm an EMS provider here in Spokane County, and I'm joined by Quinn. Quinn, welcome.
Thank you.
Give a real quick background on yourself.
Well, this is my second time being able to join you for one of these sessions, so I'm super grateful for that. I've been in EMS for about 10 years. I am a paramedic also currently in Spokane County. I work for AMR here, as well as instructing for EMSconnect. I'm hoping to go into critical care soon, and in my free time, as if the EMS wasn't type A enough, I also like to do triathlons and rock climb.
Perfect. Awesome. Well, welcome. Well, today we got kind of a combination. We've got a couple of case studies that we're going to go through, right? Submitted by EMS providers across the country. And then we put together a couple of like must-know case presentations for EMTs, right?
Yep.
What to look for, what to assess for, kind of what to, how to process those. So we'll go ahead and get started. We got this case scenario that just kind of right out the gate. This was submitted to us. So we're going to kind of work through this and we'll kind of go back and forth. So feel free again to interact with us in those comment boxes. So here's our scenario. Report of a patient experiencing chest pain at their residence. We are presented as we kind of walk in the door, right? 74-year-old male who is noted to have pink, warm, and dry skin, conscious and alert, oriented with mental status, and is able to converse with us kind of without any difficulty speaking. So right now, I'll let you kind of go first, and then I'll just kind of piggyback off it. If this was you and I are en route to the call, we're having that conversation of, hey, what are we thinking? What are some of those differential diagnoses that you are throwing on that list?
So one thing that's super important to me in my daily practice as a paramedic is that I'm always going to go worst case scenario. I don't really like to operate based off of the likelihood of something happening, even if the chances of this being a huge major heart attack or like a triple A are low. I'm still going to immediately go there, and I'm going to go worst case scenario. So I'm going to be talking with my partner en route about grabbing a 12 lead early, listening to some lung sounds, and thinking about where I am in my county and how close is my nearest hospital, or potentially thinking about flight if it might be necessary.
Perfect. Awesome. So what's number one on your list on this one?
So walking through the door, the first thing that I'm always going to want to check is ABCs, and then I'm going to go straight into my cardiology kind of algorithm that I use as a paramedic. So the top of my list right away is going to be a STEMI or a heart attack. That's kind of always my first go-to anytime that I hear a patient is having chest pain. And then after that, I'd be looking into something potentially respiratory like a PE or pneumonia or potentially a AAA as well.
Awesome. So I think those are good things to throw up here on the differential diagnosis list. And then again, this is just a starting point,
Yeah.
right? This is not, you're not bound to within those things. But this is kind of, okay, here's the blanket ideas that we're looking at. And then our assessment should be driven to either proving what we think is the problem or disproving some of these and getting them off the list, right? So I think that's a real good kind of starting spot with this is the high yield cardiacs, the heart attack up on top. As BLS providers, right now would be a good time. Do we need to add ALS?
Yeah.
Is ALS even available in your area? Maybe the only ALS option you have is by flight. So keeping those things in mind. So those of us, joining us, we don't know where you're from. So kind of have those conversations and be thinking about that specifically. So as we walk in the door, this is a little bit more information, right? Patient complains of whole chest heaviness with radiation into jaw, neck, and left shoulder. Patient also complains of non-specific generalized throbbing headache described as onset at the similar time. Patient also reports a sore throat with burning pain on talking or breathing.
Okay.
So again, we're taking this right from a narrative, so it's obviously written in a different fashion we would normally get this from a patient. But Quinn, what are the things that jump out at you as we say, like, we walk in the door and say, hey, what's going on today? And they just throw this all at you, right?
Yeah.
Chest heaviness, start at the same time, and so on. So what are some of the things that jump out at you here?
Well, the first thing is just the amount of information is really jumping out at me. This patient seems like they have a lot of complaints, which is really concerning. That makes me worry that we might have a multi-system issue going on. The first thing that's going to jump out to me is going to be the heavy chest pressure that radiates up into the jaw and the neck. That just screams cardiac to me. I'm not going to go down a rabbit hole right away, but that's definitely going to be on the top of my list to kind of investigate the more I start to interview this patient. Another thing that I think is interesting is the burning throat pain. I think that that's a little bit odd, especially coupled with the significant headache. That kind of narrows down my two top differentials to either a heart attack or potentially something wrong with the aorta.
I like it. All right. So, again, kind of have the conversations, or you can throw in the chat boxes or the comments. What are you thinking? Did you think of anything outside of MI or the AAA possibility, pneumonia? You can throw those in there if you would like. But we're going to kind of keep progressing through this case. This one is pretty straightforward. And then we're going to kind of piggyback this. This is a typical cardiac presentation. We're going to piggyback this with some atypical presentations. So as we do a baseline assessment, as a BLS provider, realistically, right, we got airway, breathing, circulations, a good baseline assessment of vitals, blood pressure, heart rate, SpO2, capnography if that's available, coupled with your end-tidal CO2. Glucose monitoring, I know we all push that pretty heavily of let's get a baseline glucose, and then doing some other assessments. So this one, as you start asking those kind of sample OPQRST style questions, we got a patient reports a weak history of progressively getting worse of the shortness of breath with kind of normal exertion, right? Now this patient says, I can't even walk a block without some sort of shortness of breath. He's sitting on the couch tonight. This pain all of a sudden just started. He describes it as heaviness. He's got that headache coupled with that. We got the radiation to the neck, the left shoulder, and the jaw. Doesn't relieve itself with any rest. Does have some no relief of pain when resting and development of nausea. We deny any chills, fever, diarrhea, vomiting, or cough. And then that shortness of breath came with the pain. So you had mentioned pneumonia before, right?
Yeah.
Does the lack of fevers, chills, cough, does that kind of take pneumonia and lower it down on your list, or where are we kind of putting
I
that
would
one?
say, yeah, I would say it lowers it on the list. It definitely doesn't take it away, but it's definitely not going to be in like my top five differentials anymore. This is really going to start making me lean towards cardiac, especially starting with unstable angina, kind of at the top of my list.
Okay. And just to kind of clarify, unstable angina, right? What
Mhm.
makes it unstable specifically in this case?
The fact that this patient is at rest is what's going to make that unstable. So, stable angina is where you have chest pain when you're like mowing the lawn or doing something exertional. And when you sit down and you lower your heart rate and you lower, therefore, your myocardial oxygen demand, that pain goes away. That's how we know that that's stable. Really concerning that this guy is at rest on the couch and still experiencing what sounds to me like ischemic chest pain.
Gotcha. And then a couple, again, high risk factors, right? Denies use of tobacco, denies use of alcohol
Yep.
or any substances, no trauma. I think that's one thing we kind of miss with chest pain, right? Let's rule
Yeah.
out the slips, trips, falls, impacts, things like that from 2 days ago, 48 hours ago, kind of ask that real broad question of, hey, anything else we should know? And it is important because I know some of our BLS providers are probably starting to think kind of their treatment plan. it's important to know that he has already taken the 324 milligrams of aspirin before we even got there,
Yep.
right? Which is great because we know that medication takes a while to get on board, right? I think we're looking at a 45-minute range
Just
to where it
about, yeah.
starts actually working. So it's awesome that person has already taken that. That's great information. Anything else you want to kind of add or throw in here?
I think it's a great question to ask if your patient has already taken aspirin. Sometimes in the heat of the moment, they forget to tell you. And one of the most common dispatching models that we use in the US is called ProQA. And one of the things that our dispatchers are trained to do is talk a patient through taking aspirin before EMS even gets there. And sometimes patients don't really think to tell you that, and they'll just take more aspirin if you hand it to them. So one thing I like to ask is, did dispatch have you take it when you called 911?
Perfect. All right, so here are our baseline vitals, right? Baseline vitals, blood pressure 216 over 159.
Very high.
That is slightly alarming, right? Heart rate of 72, respiratory rate of 18. We got saturations 94% on room air. Throwing in, we're complaining at 8 out of 10 chest pain. We know what the provocation, we know what the quality is, we know what the radiation is already. And then we just got an alert patient that's got a GCS of 15. So looking at this, is the only concerning thing you're looking at is that extreme hypertension?
It's definitely the most concerning, but I wouldn't say the only concerning. I did the math beforehand, and that's a map of 178, which is through the roof. The way you can remember how to calculate that is double D's over 3. So 2 times your diastolic plus your systolic divided by 3. 65 is your low end, 110 is your high end. Anything above that, you're looking at potential organ damage. So that definitely tells me that we have something going on. Stress can elevate your blood pressure a little bit, but not to that extent. So that makes me think that this is potentially either a compensatory mechanism or like a autonomic central nervous system response to stress. So something is wrong with the body, it's trying to compensate for that. The other thing that's kind of jumping out at me is the respiratory rate of 18. So I'm told that this patient has respiratory distress, they're very uncomfortable, they have significant chest pain, throat pain, a headache, but they're only breathing 8 times or 18 times a minute. So that to me is a little bit odd almost. I would expect a higher respiratory rate in this patient. So I'm wondering if they're either taking slow, deep breaths on purpose to trying to work through the pain, or maybe that's as fast as they can breathe through the pain.
Gotcha. With the hypertension presentation and the headache, is stroke on your differential diagnosis at all here?
Absolutely, yeah. Another thing I would want to do is take a blood pressure on the other arm and make sure that it's equally elevated on the other side. It's not a perfect metric, but if there is something wrong with this guy's aorta, that would be one of the ways that we might be able to tell in the field that something's up.
Awesome. All right, great. So as we kind of move forward here with kind of the next OP QRST, no known allergies, right? Lorazepam, omeprazole, and aspirin. Already took that, right? And this is just kind of more clarifying questions on that OP or QRST. Patient complains of diffuse whole chest pain. We know the radiation already down the left arm. Pain is described as uncomfortable heaviness associated with air hunger, which is just difficulty breathing, right? Really not able to replicate that pain upon palpation,
Okay.
which I think is one of those great questions that we kind of forget as, especially EMT, where, realistically they say chest pain. Okay, does it change when I push? Does it change when you move? Does it change when you breathe?
Yeah.
Right? Because then is it musculoskeletal? Are we talking respiratory, or are we thinking cardiac? And really, if it's changing with respiration, then maybe we can be thinking about something respiratory, right? If it's changing with palpation or movement, maybe it's something musculoskeletal. But if it's not changing, if it's not replicable with any of those things, to me that takes that cardiac event and makes it much higher on that differential diagnosis. So no change with deep breathing or movement. Onset was about 30 minutes,
Okay.
right? All right. So where are you at with your differential diagnosis? You still thinking we got cardiac real high on the list?
Yep. So a cardiac event is still my top differential at this time. With that blood pressure and that headache, I also am super concerned about potentially a hemorrhagic stroke as well. And then one thing that my medical director taught us is that any cardiac symptoms with additional neurologic symptoms as well. So a weird 12 lead plus maybe stroke-like symptoms or cardiac chest pain plus a headache. I'm definitely going to have AAA as the third on my list.
Awesome.
Yep.
And I think as BLS, right, we're talking about a couple of things. We mentioned MAP, which some EMTs feel like is way out of their scope of practice. Well, math is part of your scope of practice,
Yes.
right? So being able to calculate that, having knowledge of MAP, understanding the anatomy and physiology and pathophysiology related to that is just another tool we're throwing in there, right?
Yeah.
Same thing with you have a chest pain patient and differential diagnosis real high on your list is we think this is cardiac. And we also have that neurological component. Just because we can't interpret the 12 lead
Yeah.
doesn't mean we still can't have a high suspicion that this is a pretty major
For sure.
cardiovascular event.
Even as a medic, up until now, when we do and then interpret that 12 lead, my assessment tools and my kind of delineation and how I go into this patient's chief complaint is not that different from a BLS provider's.
Perfect. All right. So again, just kind of be thinking through your process of, what do you think is going on? What would be your game plan? And I think realistically for me, the big questions popping in my head as an EMT, right? Do I need ALS at this point?
Yeah.
Arguably, if we're waiting for introduction of ALS this far into our call, then we're probably a little bit behind the eight ball, right? Recognizing that this was a pretty high critical patient right from the moment of go
Yeah.
would have been important, right? But maybe you don't have ALS. Maybe this is, hey, we're all done asking questions. Let's just put them in the back of the ambulance, start headed towards. We know it could be a 5 minute drive to the hospital. We know it could be an hour and 5 minute long to the hospital,
Yeah.
right? So treatment plan. If this was back in your EMT days,
Hmm.
right? We patient already took aspirin.
Hmm.
We know most protocols don't allow nitroglycerin administration unless the patient has a prescription for that, which
Yeah.
he doesn't.
Yep.
So what would be your treatment plan for this individual as at the EMT level?
So at the EMT level, the first thing I would want to do is just get going, whether
I
my
love it.
hospital is 5 minutes away or an hour away, like you said. In the field, there's not really much that I can do, and I'm definitely concerned that he is having some sort of significant event. So plan A is to just get going, and there's not really a whole lot that you can't do on the way to the hospital. Even as a medic, I can do everything en route. Another thing that I would do for this patient is put on some low flow O2, just a little bit. He's already at 94%, which is awesome. But because if he is having a cardiac event, that increased oxygen demand is going to be concerning for me, especially with such a high blood pressure. So I'm probably going to throw on 2 or 3 liters, not an NRB at 25. I think that's overkill, but just a nasal cannula. If I do an end tidal nasal cannula, then I can also start to monitor some of that as well. En route, I'm going to do lung sounds, and if I do end up calling for an ALS rendezvous or when I'm calling to the hospital, I can say I hear maybe a wheeze, maybe some crackles. I can reassess that. And then I'm going to do my blood pressures every 5 minutes or less, and I'm going to make sure that I continue to swap arms back and forth to make sure that it's the same on both sides.
I love it. And if your agency or your protocols allow at the EMT level to start IVs, this is a great patient to get IV access in
Absolutely.
the field. If nothing else, something goes wrong, right? We have that fluid resuscitation option, as well as the hospital is going to want blood, as well as IV access for other medications. And maybe it's just helping out the next advanced provider that's going to be
Yeah.
joining you. Would you justify this patient a lights and sirens response to the hospital, or would you say this is okay for a no code?
If I was a BLS provider, I would go code just out of an abundance of caution. I think that that's something that I would do. Even as an ALS provider, I would definitely be considering it. Kind of depending on what my 12 lead shows, I might kind of weigh the benefits of how much time am I saving. Going code is obviously a lot less safe than going no code, but with limited information from the BLS perspective, where I have all these top differentials and not a lot of tools to rule stuff in and out, I think I would go code.
Yeah, and I think if you're joining us and you're at the advanced EMT level, this patient is a great candidate for nitroglycerin,
Yes,
right? And probably more than one, as long as that pain stays up and our blood pressure sustains that
absolutely.
after we get the IV established, right? Let's get that
Yes.
IV established and make sure we have that fail safe.
After a fast exam as
Yeah,
well, which we'll talk about a little bit later. But if this patient's fast positive or has a LAM score above 1 or 2, I probably would hold off on the
yeah,
nitro. But as long as we have an IV in place and we're fast negative, absolutely nitro.
sweet. And we'll mention we're going to come back to lambs as we get into
Yeah.
the part of the stroke, right? So that patient, right? The way the case scenario ends with the narrative that I got was interesting. Was
Yeah.
the patient ended up in triage, which
Okay.
I didn't really think was the best place for a patient that I thought was pretty high risk cardiac.
Yeah.
But who am I to tell the nurses or doctors what to do? So, but this patient, there wasn't much follow up other than get to the
Okay.
hospital and manage. This did just happen to be a submission of an advanced provider. So nitroglycerin was given numerous
Perfect.
times.
Okay.
An IV was established, numerous serial 12 leads. I didn't really look. I looked at the 12 lead, but I don't know what the 12 lead actually showed. But I think as a BLS provider, that's just a great, good, straightforward cardiac case, in my opinion.
Yeah.
If they hadn't been given aspirin or they hadn't taken aspirin before, would have been a great candidate for us to go ahead and give that aspirin.
For
So
sure.
now, do you want to? Let's talk about the atypical presentations,
Yeah.
right? This is much more. This is not nearly as cut and dry, right? And important because if we miss these patients can have some irreversible damage.
Yeah, absolutely. And these are the patients where things do get missed. So the case review that we just went over is a very typical presentation of a cardiac emergency. So crushing chest pain, shortness of breath, jaw pain, all of that is typical complaints that I would expect to hear in a patient that was having a STEMI or an MI, which is a myocardial infarction. Unfortunately, sometimes they're not always going to present like that. We're not always going to get that crushing chest pain. We're not always going to get the radiation to the jaw pain. So we're going to talk about some atypical presentations next.
All
So
right.
there's two main demographics of patients where you're going to have those atypical presentations for the most part. It's geriatric or really any postmenopausal female patient often presents with abnormal or atypical cardiac signs. And then the other one is going to be diabetic patients, or really any patient with a significant amount of comorbidities or other chronic health problems that are wrong with them. But postmenopausal women and diabetic patients really do not have that typical crushing chest pain or chest pressure type presentation. Really, any ACS or any kind of acute coronary syndrome that they might experience does have the potential to present with these abnormal signs. So it's not 10% of the time they'll present odd or 50% of the time. It can be any heart attack or any cardiac event. You have the potential to see some weird presentations that don't fit that typical textbook look of an MI. For diabetics, the reason that they have an atypical MI presentation is because a lot of them deal with some centralized neuropathy. So we all know that diabetics often have issues with their feet. They have peripheral neuropathy where they have wounds that they don't know about. They develop infections. It's something that they have to deal with at a peripheral level in their feet, but then also centrally throughout their body. It's something called autonomic neuropathy. So they experience pain in a different way than, say, a younger, healthier patient who doesn't have that neuropathy. For women, they experience a higher prevalence of something called non-obstructive coronary artery disease, which affects the smaller vessels of the heart as opposed to the larger vessels that your 40 to 50-year-old male population might experience. On top of that, women also have some hormonal changes that come with being menopausal or postmenopausal, and a lot of studies have shown that women have different and sometimes better pain tolerances than men do. So we have different vessels that are affected, and we have a different sympathetic nervous system response to pain. Often our pain is a little bit more blunted. Women handle it a little bit better than some male patients do. So when we talk about women and CVD, which is just really any kind of heart problems or any sort of coronary vascular disease, a lot of the times women will tend to be dismissive of their symptoms through no fault of their own. But since they don't have that typical crushing chest pain or pressure that we always talk about, unfortunately, sometimes we will write off the symptoms that we do have and we won't think too much of it, even though they are concerning signs for potential MI. So things like nausea, dizziness, shortness of breath, back pain, isolated jaw pain that's not associated with chest pain, all of those can be signs of a cardiac event in a woman or a diabetic patient. Women also have some gender specific risk factors that men don't have. So things like being postmenopausal, any woman that experienced preeclampsia, things like lupus and rheumatoid arthritis that kind of disproportionately affect women more than they affect men. All of those can kind of alter the experience of a cardiac event. Unfortunately, and this is kind of my Roman Empire in EMS, this is something that's really important to me, but a lot of women do report that they don't feel like their healthcare providers listen to them when they're experiencing pain. So that's a large part of why CVD goes underdiagnosed in women because we have different risk factors and we have different presentations. So in 2024, the KFF, which is the Kaiser Family Foundation, did a survey, and a lot of women, I think it was 1 in 4, reported within the last 2 years feeling disrespected or unheard by a healthcare provider. So just because a female patient is experiencing chest pain or these abnormal symptoms does not necessarily mean that she's just having anxiety or that it's something to overlook. A lot of these kind of more mild symptoms like just the nausea or the dizziness should be taken very seriously.
And that's what I like in that first case study was clearly the question was asked of like how active are you, right? Because
Mm-hmm.
they said normally they they could exert themselves with no shortness of breath,
Yeah.
and then it said, but recently I've noticed that I can't even walk a block, right? And I
Yeah.
think in this population you're talking about specifically is how active are you? Well, normally I go walk with all the ladies in the neighborhood,
Yeah.
but the last week I haven't been able to because just walking to the mailbox gets me short of breath. Like those are the
Exactly.
things, those are great, like that EMS detective that we talk about so much of like, you're not restrained to OPQRST and sample that
Yes.
you were just badgered with in your EMT program. There is a million other questions you could be asking, especially if you're just in the information gathering phase of this assessment.
100%. Another thing that's really important to note is that your patient is also never too young for a heart attack. There's been a lot of studies that show that the instances of MIs and CVD in younger populations is increasing significantly, with one case report showing the MI in a 19-year-old male. So just because your patient is 40 and female doesn't necessarily mean that she's just having anxiety or that her symptoms are something to write off. Any weird symptoms should be taken seriously, and I think an MI should be considered at basically all times.
Great.
Yeah. So, from a BLS perspective, like we talked about kind of in that case review, there's a couple of things that we can do just right off the bat. The first of that is always going to be assessing our ABCs. Any patient who's experiencing a cardiac event is going to probably need some supplemental oxygen. Again, an NRB, probably overkill. But if they're sitting at 94, 95% in a young, healthy person, that's usually pretty okay. But since these patients' hearts are working harder and have a higher oxygen demand, a nasal cannula at 2 to 3 liters is a great idea. A physical assessment, like you talked about, is also important. So, pressing on the chest and having your patient take a big, deep breath in, seeing if that changes their pain at all. And then pharmacology kind of depends on your local protocol. So, of course, continue to follow those. But if your protocol lets you give aspirin as a BLS provider, the earlier the better. Aspirin, as long as it's not contraindicated, is what we consider a very high reward, low risk medication. So if you give it to someone with chest pain and they end up not having an MI, they're going to be okay. Aspirin is very safe as long as it's not contraindicated. So no allergies, no recent GI bleeds, stuff like that. For nitro, again, following your local protocols, if your patient does have a prescription and they're having chest pain, then that's definitely something you can consider if you're able to do that, especially for my advanced EMTs. The one thing I would caution some providers to consider is making sure that you do have an IV in place before that. And I know that a lot of protocols have a systolic blood pressure cutoff. So they say hypotension is a contraindication for nitro, and that is very true. Most places, I think, have a systolic BP cutoff of like 90 to
I think it's
100.
90, yeah.
Yeah, I personally will operate a little bit above that. If I have a patient who has a systolic blood pressure of like 110, 112, I might even hold off on the nitro depending on what I find on my 12 lead. As a medic, if I see a certain type of heart attack, I'm definitely going to hold off on that. So if I see an inferior wall STEMI or a right-sided heart attack, I'm probably not going to do nitro in the pre-hospital setting unless my patient is very hypertensive like that first one was. In the hospital or places where you can do a nitro drip, the starting dose is 10 micrograms per minute, which is, we give 0.4 milligrams sublingual, so that's 40 times the starting drip dose. So we give little nitro bombs. So if you're going to do nitro for a chest pain patient, that's great, but just make sure you have that buffer of blood pressure and you can do something about it if your patient does bottom out.
Perfect.
And then with that, making sure that we're watching closely for shock. So our first signs of that are going to be tachycardia and tachypnea. And then keeping an eye on your blood pressure and making sure that if your MAP does start to decrease or your systolic blood pressure does start to decrease, that you treat your patient for shock. And then transporting to a PCI capable hospital. Let me see if I can get this right. Percutaneous coronary intervention is what PCI is. So any patient that's having a heart attack, they're going to go to the cath lab, and this is one of the treatments that they're going to receive. So if you have an option between two hospitals and one of them is a STEMI center and has a cath lab and has the capabilities of taking care of that patient, maybe preferring that one over the other one instead.
And I think that's great as a BLS provider. You're new to the area. Go to the hospitals, ask those questions. You're probably going to have protocols. If you've got numerous facilities to choose from, there most likely is a protocol that says patients that are high risk cardiac go to hospital A over hospital B or C. No different for cardiac, for stroke, for trauma. All those things, they're going to be laid out in your protocols most likely.
Exactly. And then our BLS treatment for shock is going to be SHOT. That's something I was taught in EMT class 10 years ago, and it's still stuck with me today. That stands for supine, so laying your patient flat if they can handle it, or even doing Trendelenburg if your cot is able to do that. Keeping them warm, giving them oxygen, and then transporting rapidly is some of the best things you can do for a shocky patient as a BLS provider.
Love it. All right, so just a couple of like housekeeping things right here in the middle that we kind of talk about. First off, here is how, again, you need information on anything we're talking about. You want to get help protocol changes or general questions about who we are, what we cost, that kind of thing. Info at EMSconnect.org. All the social media platforms, you can follow us. We're live on Facebook right now. We have an Instagram page. We have a X page. We have a TikTok page. Again, just looking for EMS Connect on those platforms. Engage with us. Great swag giveaways, all kinds of great stuff there. At the end of this lecture, as we do on all of our live sessions, we will randomly select someone to give them an electronic Amazon $50 gift card. So hang out for that at the end of this lecture. Again, all of our live lectures, we will give away one of these Amazon $50 gift cards. So stay tuned for that at the end of the lecture. Selfless plug for our podcast, EMSconnect on Shift, all those major podcasting platforms, another way of getting free education and be able to listen to that whenever you would like. And then as we kind of draw close to NREMT research, we do have 100% online self-paced CAPCE approved, which means NREMT approved refreshers. So 20-hour EMT, 25-hour advanced EMT, and a 30-hour paramedic. All of those come with great bonus hours actually added into those for that cost. So you can go to our website and click on refreshers and you can sign up for those. They're great at your own pace, great content, and all transfers seamlessly to your NREMT. All right, so let's keep going with these high yield patient scenarios with strokes coming up next.
All right. This is another one of the things that I think is kind of non-negotiable for our EMTs to know. This is something that I want to be baseline knowledge for a BLS provider, so we're going to cover that here. So we're going to talk about CVAs, which is strokes, stands for cerebrovascular accidents, and then TIAs, which are transient ischemic attacks. As a medic at AMR Spokane, I have the distinct privilege of being an FTO and a preceptor as well. So I do a lot of education at our own department, and that comes with the capability of having people come up to me and ask me a lot of questions. And so a lot of the time I'll have BLS crews come up to me and say, hey, I had this weird patient. They were totally vitally stable. Blood pressure was 130s, 140s, heart rate was good, SpO2 was good, sugar was normal, but they were completely unresponsive, or they were groaning to pain, or they were eyes open but just couldn't talk. And they get a little annoyed because I always say, oh, was it a stroke? And I guess it right away because it's almost always a stroke. So it's a very common thing to kind of run into. I don't want you to rule out other potential differential diagnoses for these patients, but if you have someone who's unconscious or obtunded but vitally stable, a lot of the time they're probably going to be having something neurological going on with them.
Will you unpack the word obtunded? Because I feel like we
Yeah,
hear that term a lot, and some EMTs just kind of like brush it off. So if you're going to call it, because I think it's a great way to document something. So will you
absolutely.
just kind of unpack that of what is obtunded?
Yeah, so it's any patient who's not necessarily fully unconscious but close to it. So someone who is very weak, very lethargic, can't follow commands, can't answer questions, really any sick patient. If you look at someone and you're talking to them and they're not really responding to you, that patient's probably obtunded.
Love it.
Yep. And if they're vitally stable and obtunded, then I'm going to be worried about a stroke primarily. So there's a whole bunch of different types of strokes, but we can kind of boil it down to three big categories. The first of which is an ischemic stroke. So this is going to be like your fast positive patient. So this is a blockage or a clot in the brain itself, in one of the cerebral arteries. This can usually cause that one-sided weakness, the facial droop, the slurred speech, stuff like that. You can also have a hemorrhagic stroke, which is a brain bleed. There's a couple different types of that, like epidural, subdural. You have a whole bunch of different types there that you'd be able to see on an MRI or in a CT. Out in the field, we just call that a brain bleed. That's kind of what we categorize there. And then you can also have a TIA, which is a transient stroke. Some people they refer to this as a mini stroke. This is like an ischemic stroke that goes away. So you have those fast positive symptoms. You can't talk, you can't move the left side of your body, but after any period of time, whether it's 2 minutes or 20 minutes, those symptoms resolve and they go away and you feel fine again. Usually the imaging will come back clear, the CTs, the MRI will look good. That most likely cause of that is going to be a TIA. Those are a little bit difficult to diagnose. That's the kind of thing that you'll say, like, okay, well, your CT came back clear and you're fine now, so it must have been a TIA. So in the field, one of the best ways that we're going to be able to kind of differentiate what sort of neurological event we might be dealing with is something called a LAMS score. So this is something that I think is really important for our BLS providers to know. This is also county dependent. So here in Spokane, when we're going to call a stroke alert, our hospitals are expecting to hear a LAMS score. So if I say AMR 135 with a stroke alert and I contact one of our most awesome hospitals, Sacred Heart, they're one of our best stroke centers. If I don't say a LAMS score, it's something that they're going to ask for over the radio before they let me go. So it's basically like a fast score with numerical values assigned to it. So you can have a lowest score of 0. This isn't like a GCS where it has to be 3. You can have a LAMS of 0. So the first thing we're going to look at is facial droop. So either it's there or it's not. Doesn't matter which side. If you have facial droop present, you get 1 point. The next step is going to be arm drift. So if you have your patient go zombie arms out in front, one of their arms slowly drifts down, that's 1. And then if it rapidly drops with no attempt at trying to keep it up, they're going to get 2 points. Same thing for the grip strength. Again, it doesn't matter which side. Normal equal is 0. If one grip is present but weaker compared to the other side, they're going to get 1 point. And then if it's gone completely, then it's 2. This is a really great metric for large vessel occlusions is what we're really going to use this for. It has a lot of sensitivity and a lot of specificity as well. Little pop quiz for you, Shaun. What is missing from this scale that is an indicator of a stroke?
Slurred speech.
Yeah, slurred speech. So you can still be fast positive with a LAM score of 0, and I still want those patients to be considered stroke alerts no matter where you are. If someone can't talk or if they have word salad or they sound like they're intoxicated but they're not, that patient definitely still could be experiencing a stroke. But this LAM score is a great way for us to say, okay, you have a score of 4 or 5. That's a really big indicator of a large vessel occlusion.
Yeah, and I think going back to that, just this is a great screenshot. If your agency just uses the FAST exam, this is a great tool. Again, nothing says in your protocol that you can't use an additional tool,
Yeah.
right? So this is great. You can look at the science behind this, just a little bit more comprehensive than that FAST exam. So if you want to screenshot that, you're more than welcome to, because this is a great little cheat sheet to put in your phone or in a note card or something in your pocket that you can utilize to help with those stroke patients.
Absolutely. And I'm a big fan of using resources on shift. So before I was able to have the scale memorized, I would pull up that screenshot all the time and make sure that I just wasn't missing anything. I think there's a lot of value in that. So as a BLS provider, when you're assessing your stroke patient, I do want you to ask your sample questions, but then there's a lot of stuff that's also really important to go beyond that. The most important thing to ask for these patients is, what was the time last known well? The reason for that is when you go to a stroke capable hospital, they can receive something called lytic therapy. So thrombolytics, a really common example of that is a medication called TPA, but that's very time sensitive. It has kind of this multi-hour window where it's going to be at its most effective. I have found that kind of varies facility to facility based on protocols, but the average time for TPA administration is about 4.5 hours or less. So if you're not within that window, then your patient's not going to be able to receive the drug therapy. And then the sooner that you do a clot retrieval therapy, the better within that first 24-hour window of that onset of symptoms. It's also really important to know if these patients take any blood thinners. True anticoagulants can kind of mess with that TPA, so that's contraindication for that. And then any recent falls or trauma, especially with slurred speech. So that could definitely be an ischemic stroke, but if you fell and hit your head yesterday, you're on blood thinners, and this morning you woke up completely unable to talk, I'd be worried about a brain bleed in that patient. Another really important thing to ask, especially when patients wake up with stroke symptoms, is, what was the time that you went to bed? And when did you start to notice this kind of deviation from normal? Especially if you have family present, a really good thing you can ask is, what does normal look like for this patient? Do they know where they are, who they are? Could they tell me the year? Are they able to speak coherently? Unfortunately, if someone wakes up with stroke symptoms, we do consider that last known well the time that they went to bed. So it's not the time that you wake up as your last known well or your symptom onset. We have to go back 12 hours because we don't know that time period during the night where those symptoms might have started or when that occlusion might have occurred. So unfortunately, it does have to be bedtime for those patients. So before you leave, when you have family on scene, make sure you're asking those questions, and then make sure you're checking a blood sugar. Don't take your stroke patient to the hospital, lights and sirens. You get there, hospital does a point of care glucose, and it's 20. That's really embarrassing.
Yeah, not something you want to do twice.
Yeah. All right. So another thing that I wanted to cover just for our BLS providers again, which is something that was kind of glazed over when I went to EMT school, is sepsis. I think that this is another big one. The reason that I wanted to cover this is because not all infections are sepsis, and not all sepsis is severe septic shock. So we kind of have this multi-tiered approach that came from a lot of different resources. There's the National Surviving Sepsis Campaign, which is a big contributor to a lot of this data. It kind of builds upon itself. So we can see in our first section there, SIRS, which is a systemic inflammatory response syndrome, you have kind of this baseline set of vitals, and then the next couple of categories sort of build up from there. Where most EMS protocols fall is severe sepsis or septic shock. So when we're in the field and we're going to call a sepsis alert, that's the kind of thing that we're looking for. Another quiz for you. What are the 2 most important vital signs that we're going to be looking for when we're considering or when we're worried about septic shock?
I'm going to say systolic blood pressure
Okay.
and heart rate.
Close. Systolic blood pressure is very important, and that's definitely going to be a shocky sign if your patient does have a systolic BP less than 90. Increased heart rate is super important, and then increased respiratory rate is really important as well. It's not just true of septic shock, but really of all shock or all hypoperfusion. One of the first things that I'm going to be looking for, and that's going to be a red flag to me, is an increased respiratory rate at rest. So if someone's blood pressure is okay, their heart rate's in the 90s to 100s, but they're breathing 30 times a minute, their body's fighting something. They're in that kind of fight or flight response. They're probably dealing with a pretty significant infection. The name for that is occult shock, which is something that's, I think, important for BLS providers to know. The treatment plan won't really change, but occult shock is kind of the first initial phases of shock where your body is in a state of hypoperfused, like metabolic state, but your vital signs are going to be good or almost normal. So when we do start to get into severe sepsis, and when we start to get into a really significant systemic infection, we're going to see a couple of hallmark signs. A lot of agencies have protocols that are some combination of these couple of signs. So the first thing you're going to look for is that increased respiratory rate. Sort of like a diabetic, it's not the same as Kussmaul respirations, but they will be rapid and deep, and that's due to some metabolic acidosis that happens with severe sepsis. And then same thing with the increased heart rate. A lot of protocols will actually start that metric at 90 or higher. So instead of 100 or higher for our normal like sinus tach range, we'll consider 90 or higher to be an increased heart rate, specifically at rest. A low blood pressure is a really common finding in severe sepsis or septic shock. So any MAP less than 65 is what I would consider a low blood pressure. A lot of people like to just kind of rattle off 90 over 60, but that I think actually comes out to a MAP of like 72. So I'm going to be looking at that number in parentheses on my machine next to my blood pressure. Initial phases of septic shock, your blood sugar is actually probably going to be a little bit elevated. Even if your patient is not diabetic, that's a sign of distress in the body. And then some confusion or altered mental status and fever are also going to be good indicators of severe sepsis. It's also important to note what kind of patient you're dealing with and if they can handle these symptoms. So the very old or the very young, especially with multiple comorbidities, are going to handle this shock a lot less well than a young, healthy adult would. So if you're already looking at a low blood pressure and a high heart rate, and you're dealing with someone who's 90 and has a laundry list of medical issues, they're going to be able to compensate a lot less than another patient would.
Well, I think it's important. We think of sepsis and geriatrics, right? I feel
Yeah,
like that's in our brains, but what we forget is those very young.
yeah,
Sepsis is also, I wouldn't say common, but a possibility.
yes,
And I think it's overlooked,
yeah,
right? We kind of pass it off of, oh, they're just sick. But again, the sickness could have led to something more life-threatening.
yes,
So really
absolutely.
be aggressive with those assessment techniques in that younger population.
Absolutely. Another thing that I like to include that I find interesting is that a sign of severe sepsis is mottling in the extremities. So if you have a patient whose vitals look okay, but you do a skin exam on their legs and you find that they're mottled like that picture, that to me is also a red flag. And then we always go back to shot for our BLS providers for shot care, whether it's cardiogenic shock or a septic shock. We want to lay them supine or Trendelenburg as long as they can breathe in that position, keep them warm, give them oxygen, and transport rapidly. Okay. All right, next up, I wanted to talk about seizures a little bit, both epileptic and non-epileptic. This is something that I also think that kind of gets touched on in EMT school, but is not made a priority as far as education goes. So again, there's so many different types of seizures and neurological emergencies, but we're going to break it down into kind of three major categories. The first of which just being a healthy, normal brain that's functioning correctly. The second type of seizure that I want to look at is a focal seizure. So this is not generalized activity in the brain that's going awry, but it's abnormal electrical activity in one spot in the brain. And something that's really important to note here is that someone who's having a focal seizure is having a seizure, but they're not going to have that typical full tonic-clonic presentation. So they might still be able to talk, they might still be able to move one or more of their extremities, but that does not necessarily rule out them having a seizure. And then the generalized epileptic seizure is where you're going to get that classic like tonic-clonic, your patient's tight, they're locked to one side, usually breathing very rapidly, not really responsive, not able to follow commands. That's your classic seizure sign. So you have epileptic seizures and then you have non-epileptic seizures. These used to be called pseudo seizures, and now we are starting to get away from that, which is something that I am very grateful for. That was very misleading for a lot of providers who would assume that those seizures, since they're called pseudo seizures, are not real or not valid or not something to be concerned about, and that is not true. So now instead of calling them pseudo seizures, we're going to call them PNES, which is psychogenic non-epileptic seizures. This is most common in young adult women, so anyone in between the age of like 18 to 30 is where you will normally see this the most. And then it's often associated with other comorbidities like PTSD, migraines, anxiety, major depressive disorder. These account for a large percentage of patients in neurological or epileptic monitoring units, and these are real seizures that should be taken seriously. They are not epileptic seizures, but they're not nothing. It's not just always psychosomatic. It's not something that your patient is necessarily doing on purpose or making up. It's something that I want to treat as real. So, a good rule of thumb to decide if your patient is faking their seizure or not faking their seizure is to just tell yourself that they're not faking it. You don't stand to gain anything from assuming that it's not real or that it's just psychogenic in nature. It's always the safest bet to assume that your patient is really seizing and to treat it like that, especially from the BLS perspective, where your treatment plan really is not going to change very much. You're still going to maybe turn them on their side to help do some airway control, keep them in a nice open area or on the cot where they're not able to run into any furniture. If they're upright or sitting in a chair, lowering them to the ground so that they don't fall and hit their head. Nothing is really going to change, and when in doubt, you should assume that it's a real seizure and treat it as such.
All right, so we got another one of these great case studies just kind of popping in. This one, we had a couple different submissions for this. This one was just kind of unique, right? The first one was kind of
Yeah.
straightforward. This one had it was an interesting case. So here's our dispatch information. 47-year-old male, possible electrocution. Patient also complains of chest pain. So let's just say en route to the call, right? What's that conversation look like between you and I of, so what are the possibilities? Obviously, electrocution has its own, we got burns, we got damage done to the skin, but then
Yeah.
this patient's now also complaining of chest pain. So I'll field this to you first of kind of what are you thinking with possibilities of what we're going to have to manage when we get there?
I think this patient might be in VDAC. I'm definitely concerned about some cardiac involvement. Depending on how much electricity was introduced to their body, that can definitely cause some dysrhythmias that I would be really concerned about. I'm also concerned still about the physical trauma, about entry point, exit point for that, and I'm concerned about scene safety as well. But one of my top priorities is going to be assessing kind of the hemodynamics of my patient and making sure that we don't have one of those critical dysrhythmias.
Great. That's awesome. That's kind of all, again, thinking of the actual damage and then some of the damage we may not be able to actually see.
Yeah.
So here's kind of the information we kind of get, let's say as we walk in the door, right? Patient reports electrical shock from foot contacting a baseboard heater. They're able to tell us it's a 220 volt heater. There was a loss of consciousness. They're now kind of collapsed on the floor, but they're conscious, right?
Okay.
They are reporting chest pain as well as shortness of breath. So anything jump out at you here that seems, I don't know, it's strange or concerning?
Uh,
To me, the loss of consciousness,
Very concerning.
yeah, that's pretty substantial amount of
Yeah.
electrical shock. Whether that's psychosomatic and it was just mentally they went unconscious or had some sort of syncopal episode, or it was truly enough electricity to cause a pretty substantial loss of consciousness.
Yeah.
What else in this is concerning for you?
The chest pain and the shortness of breath are definitely concerning to me. And then with that loss of consciousness, like you said, even if it was just kind of a psychological response to what happened, when you pass out from something that is startling or upsetting to your body, it's usually going to be a vasovagal response. So when you vagal out, as we call it, your heart rate and your blood pressure are both going to drop and you're going to lose consciousness. And most young, healthy people, as you start to wake up, both will kind of normalize by themselves. We can do IV fluids, we can do positioning, but it's a transient thing. My concern is that if we have this insult to the body, so we have a significant amount of electricity come through, coupled with a sudden drop in blood pressure and heart rate, if you are in some kind of dysrhythmia, or if it did do cardiovascular damage to your body, are we going to be able to get that heart rate and that blood pressure back up, is my concern.
I like it. So more information specifically on this case, right? As we're kind of going through, looking at what else we got. Again, be thinking about things you'd be looking for. Again, we're just basing this on our own interpretation of this case scenario. So we get there, we have patient contact, we start looking for physical damage, right? So what we find is we have a small circular pinhead sized burned area on the tip of the left great toe, right? So big toe, small amount of grease or soot, kind of easily wiped off. So we're not really concerned about any sort of like deep tissue injury,
Yeah.
right? We got movement and sensation are present, which is great news. Patient reports pins and needles tingling throughout their scalp, also as well as their arms, hands, legs, and feet after the event. Cranial nerve 2 and what is that, 5, 6, 7?
7.
Grossly intact on the exam. No evidence of ataxia, right? So no gait issues, balance issues. We got good muscular strength. Sensation appears to be intact, both on the light and firm touch, dull and sharp assessment. And we don't have any signs of any electrical injury to the mouth or tips or the lips or tongue, right? So talk me through this assessment. What are some of the things, like this provider obviously did a real thorough exam.
Yeah.
Are you always checking cranial nerves? Talk to like kind of give that knowledge to the EMT of how do we assess cranial nerves 2 and 7 or other cranial nerves?
Yeah. I just want to say kudos to the provider that submitted this report and documented this way and did this super thorough neurological assessment. I am very impressed with what I'm seeing. I think this goes above and beyond what a lot of providers do, and I think it's absolutely fantastic. The cranial nerves are not something that I have memorized because I don't think there's value in using that brain space to have all of that memorized and knowing which one is which when you could just pull it up on a reference card super quick. I do like that they are going through things like the eyesight and the tongue movement and sensation. That's one of your cranial nerves. I like the difference in touch they're doing. So light versus deep stimulation of the skin. I think that that's fantastic. And this looks like just about something that I would do on an electrocution patient at the start, especially with the physical exam. I think this is great.
Yeah, and the good news here is we have some affirmation that there was electrical contact, right? We
Yes.
have some sort of injury to the foot, even though, I mean, I'll tell you, kind of as this unfolds, there was almost that little sneaking suspicion that maybe this wasn't nearly what happened, but
Yeah.
whether it was enough electrical conductivity to cause loss of consciousness as a uh, because of the electrocution or more of like that psychosomatic response or not. But we do have some good affirmation that there was some electricity that did
Yes.
enter the body, which I
Yeah.
think is important to kind of note as this unfolds.
Yeah.
Vital signs wise, blood pressure 162 over 110. We got a heart rate of 102. We got a respiratory rate of 20. We got good saturations at 96% on room air. We're conscious, alert, and talking with a GCS of 15. Anything here jumping out at you? To me, this seems like a pretty good worked up response,
Yes.
right? A little bit hypertensive, but again, I mean, they're probably pain,
Yes.
probably some, fight or flight adrenaline style
Yeah.
response, which heart rate matches that, respiratory rate matches that, blood pressure matches that. Anything here that jumps out at you?
No, I think this looks good. This is kind of what I would expect to see. Hopefully, that blood pressure kind of starts to work its way down during transport and throughout the rest of the assessment. But right now, I am not surprised by any of this, and I think it kind of matches the scenario for sure.
Perfect. So, sample and OPQRST questions. Allergies to penicillin, doesn't take any medications on a regular basis. We got a past medical history of behavior and anxiety disorders. That's where I think you start to kind of let that little intrusive thought of, so is this an anxiety response that
Yeah.
did they get a little bit of a shock? I mean, I don't know about other people listening, but I've definitely accidentally had my fingers on the prong of something, plugged it into the wall, and you get that response that
Yeah.
feels like being electrocuted, right? Is that where the intrusive thoughts started to come? And then towards the end of this, you'll see that they're intrusive thoughts. But
Yeah.
patient denies any cough, nausea, vomiting, diarrhea, no other real associated symptoms of shortness of breath or skin paresthesia, which is that pins or needles feeling.
Yeah.
Patient denies any trauma during the event. So no, even though it said loss of consciousness, but no fall to the ground, no strike to the head, nothing like that.
Yeah.
Patient does admit to using heavily caffeinated energy drinks earlier in the night, and then does admit to taking a THC gummy before the event happened.
Okay.
I think that shoved the intrusive thought even deeper into the
100%.
forefront of my
Yeah.
brain, right? So here we have someone who admits to THC gummy, highly caffeinated, which could lead to the blood pressure and heart rate issues.
Could.
And then again, behavior and anxiety disorder. Again, keeping that clean slate. Everyone is telling you the truth until you
Yes.
can medically prove it otherwise, which in this
Exactly.
case, I don't really have a reason not, because we do have an electrical contact
Yeah.
evidence on the body.
Yeah. I think it's great that you brought that up. One thing that I like to tell my new providers is that anxiety is a symptom and not necessarily a diagnosis, especially in EMS. So you can be having a heart attack and be anxious. You can get electrocuted and be anxious. Anxiety is a symptom of severe shortness of breath. It's an anxiety or it's a symptom of pain. So anxiety is a real possibility here, but it doesn't negate or take away from the possibility that a real electrocution did occur. Same thing with the THC gummy. If anything, that should chill your patient out. And the fact that they're still tachycardic and hypertensive makes me a little bit concerned that something might have happened. And that goes back to we're going off worst case scenario. We're not going off of likelihood.
Right. All right, great. So differential diagnosis, obviously we have electrocution. We
Yeah.
have evidence of that,
Yep.
right? As a BLS provider, my thoughts here are realistically, like management wise,
Mm-hmm.
bandage that area,
Yep.
even as small as it is, make some sort of like psychological first aid, right? We're doing something for you.
Yeah.
Let's make sure we bandage the toes individually, if that's on the inside of the toe, whether that's the outside of the toe. I mean, I feel like this is kind of like, let's put a Band-Aid on it, right? Not literally, but let's put a Band-Aid on it. Let's provide some care.
Yeah.
And then really this is going to be a transport and management into the hospital.
Yeah.
If you're able to take EKGs and you can't interpret them, that's fine.
Mm-hmm.
But taking a 4 lead or even a 12 lead on this patient, they are complaining of chest pain, monitoring end-tidal CO2, monitoring waveform, throwing the SpO2 on. I really can't justify taking blood pressures every 5 minutes. I think this patient's fairly stable,
Mm-hmm.
but I guess with a long transport and you want to feel like you're doing something, then sure, why not take
Yeah.
vitals every 5 minutes?
Yeah.
But what else are your thoughts? Anything that we're missing kind of as this case kind of wraps up?
I don't think we're missing much. I think we're off to a really great start. One thing that I don't want to ignore is that loss of consciousness. Even if the electrocution didn't do any damage, passing out certainly can. And then any patient who loses consciousness or has any kind of trauma, whether it's electrocution or otherwise, I'm going to be concerned about a fall as well. So en route, I would want to explore when you lost consciousness. Did you wake up on the ground? Did you hit your head? Any head, neck, or back pain? We know this patient doesn't take any blood thinners. That's a really good thing to ask as well. And then maybe a C-collar. Anyway, if your patient did fall, even if they're not sure if they hit their head, I don't think it's a bad idea.
Right. And I just because we're saying C-collar does not mean backboard, right? Those are
Just
no longer
C-collar,
married,
no,
right? Those are
just a
divorced.
C-collar.
Yep.
Yeah.
Spinal motion restriction allows a
Yes.
C-collar application without a backboard.
Yep.
Um,
As
we-
an ALS provider, I would be really happy if I was handed this patient with a C-collar in place and a 12 lead given to me ready to go. I would not be happy if they were fully backboarded.
yeah, they're gonna. Yeah, that's just again, those are divorced. They don't.
Yeah.
They don't ever have to speak ever again.
Yeah.
So, all right. So that was kind of the last of our case studies,
Yeah.
right? Real quick, just review of some of the major like paramount things that we talked about, right?
Yeah.
So what are those big high yield takeaways from today?
So first and foremost, we want to make sure that we're not ignoring our atypical MI presentations or any kind of CVD presentations in our two kind of abnormal presentation patient populations, which is our postmenopausal women and our diabetic patients. Okay. We also want to know that an obtunded patient who is vitally stable or mostly vitally stable has a high likelihood of potentially having a neurological emergency. One of the things you can do is look for slightly irregular respirations, which can help with that. When we say time is brain, we really mean it. During an ischemic stroke, you lose almost 2 million neurons per minute. So the sooner you recognize this and get going, the better. We want to know that not all infections qualify a patient as septic or approaching septic shock, but we want to know the early signs of that. So our tachycardia and tachypnea, if you see those, you can go ahead and get ahead of the ball. If it's in your scope of practice, an IV and fluids for these patients, even if they don't meet septic shock criteria, is a fantastic idea. Not all seizures are epileptic, but they all deserve to be taken seriously, especially in the field as an EMT or even as a medic. It's not your job to diagnose, it's only your job to stabilize and transport these patients and treat them with respect and respect their autonomy.
Yeah.
Yep.
I think the big thing, like I said, at the EMT level, it like education gathering, right? Just because
Yes.
you can't use something at your scope of practice, we always encourage BLS providers take an ACLS course.
Yes.
Just because you can't use the ACLS medications, you can gain the knowledge, understand what they're for, how they work. If you work with a paramedic partner, it makes you even more valuable. But again, things like MAP, like you're talking, being able to calculate a MAP and
Yeah.
knowing what that looks like. And, just because you don't have a paramedic that can, or maybe your protocols don't allow you to call a sepsis alert in the field, you can still know that the patient qualifies for a
Yeah.
sepsis alert in the field, right? It's just education gathering is going to make you a better provider. So, as we kind of wrap this up, if anybody has any kind of lingering questions, please let us know, whether that's in the chat box or the comment box. We got people monitoring all of that. But kind of as we wrap up here, our Amazon $50 winner today is Kim Sharp. Congratulations, Kim. We will reach out to you. We will make sure we got your email address and be able to send you that gift card. Again, we give this away every single live lecture, just for thanking you for joining us. You don't have to be a member of EMSconnect. It's just for joining us. So congratulations, Kim. Buy yourself something nice. Those of you that are EMSconnect users, as you head over to the EMSconnect platform and take your post test, it's pretty straightforward post test related to some of the general information we talked about, but there is a CAPCE required survey before you take that post test. Allows us to get some feedback from you, what you like, what you didn't like, what you want to see more of. So please fill out those CAPCE surveys with constructive criticism, right? The ability for us to grow and learn and understand what you would like to see more of is super important to us. And that post test, again, if you are an EMSconnect user, you log over or log into the emsconnect.org platform. You'll hit courses. In the middle of that, or on the top of that courses category, will be this lecture, right? BLS Essentials live case studies. And the right hand side of that will be a take exam button. It will be unlocked for you if you joined us on webinar. So keep that in mind. Those of you joining us on YouTube, TikTok, Facebook, if you want to take the post test on your account, you're going to have to email us and let us know you attended. But everyone else in the webinar, that should just unlock for you. So thanks, Quinn, for joining us
Thank
like
you.
usual. Thank you, everyone, for joining us on the different platforms. And we will look forward to seeing you on the next live lecture.